Good morning, everybody, and thank you for joining us for Grand Rounds. It is my pleasure today to introduce today's speaker, Dr. Mohamed Abazeed. Dr. Abazeed is an associate professor of medicine at Northwestern University and the co-leader of the lung cancer program in the Lurie Cancer Center. As a clinician, he is focused on the management of patients with lung cancer. And as a scientist, he and his research team have developed methods and information capabilities that advance more individualized cancer treatments. Please ask any questions for Dr. Abazeed in the chat, and we will get to them at the end of the presentation. Thank you, Dr. Abazeed.
Thank you so much, Aparna, for that introduction, and thanks everybody for being here on this festive Friday. Happy St. Patty's Day. I found the only green shirt in my closet, and I'm wearing it on this occasion. So it's a real pleasure to be able to talk, I think for the first time, to Northwestern University since we moved here in 2020. We'll be able to share some of our research program historically and also things that are pending and our future directions. So when folks ask in a sentence or two, what does your lab do? I really like this figure because I think it illustrates a lot of what we're trying to do, which is to find these very subtle signals in large data sets. My background is in human genetics and computational biology. Our lab is interested in big data to be able to guide specifically clinical predictions on oncology. And as a radiation oncologist, obviously, a big emphasis in the laboratory is predicting response to ionizing radiation. So here are my disclosures. I will be talking about the anti-KRAS G12C inhibitor from Amgen, not from Mirati. And then we do have a lot of academic industry partnerships. So I think all of us are aware of what precision medicine means. But let's review it from the perspective of a radiation oncologist. So the promise of precision medicine, which I think has been in part realized over the last decade in oncology, is that historically we treated patients as heterogeneous mixtures. These patients had individual germline and somatic tumor mutations. And when we ran randomized controlled studies, we typically applied a therapy across these two distinct populations. And we thought we were doing a really good job of making sure that those two arms are as random as possible. However, it became increasingly clear that that can obscure some key signals within those populations. And a great example of that is EGFR mutations in patients with lung cancer. So a lot of the original anti-EGFR therapies, gefitinib and erlotinib, failed large-scale randomized controlled studies. It wasn't until the Pan-Asian study using IRISA showed a signal in female Asians, younger female Asians. And many stories later, many publications later, it's because they had EGFR mutations. And so there's clearly a value in identifying a subset of the population and personalizing that care by giving them drugs that they're more likely to respond to. What does that lead to? That leads to enhanced efficacy and potentially a reduced toxicity. And so when we think of biomarkers in medical oncology and biomarkers in surgery, those are typically binary choices. What I mean by that is you either operate or you don't operate, or you either give a drug or you don't give a drug. Of course, there's some dose reduction schemas in chemotherapies, but I think those are the exceptions. However, in radiation therapy, we have, I think, the unique ability, or nearly the unique ability in oncology, to be able to titrate our doses. So it's not a binary decision. The extent of radiation can be titrated in increments of granular gray, which is our unit of dose. So historically, when we think of drug biomarkers, you either want to know, does my patient have a mutation? Do they have a translocation or do they not? However, there is tremendous benefit in understanding the continuous likelihood of responding to a particular therapy for radiation oncologists. The other critical aspect of making predictions, of course, is we'd like to make time to event predictions. I don't simply want to know if a patient receives my therapy, whether they're going to have a local failure or not at some point in the future. I want to know what is their likelihood of local failure at 3 months, 6 months, 12 months, 24 months, because clearly that can impact my decision. If I'm willing to bear the extra risk of increased dose, I'd want to know if the patient is likely to survive beyond 3 months or 6 months or 12 months. And so, coupled with overall survival estimates, I think that can really be informative. So the concept is really quite simple at the elevated level. Identify patients that are more resistant and less and more sensitive to radiation in a gradated fashion. If you can do this prospectively, then one could adjust the risk by calculating the risk of failure of the treatment, and then make an adjustment in the dose of radiation, and then potentially deliver not just customized, spatially personalized radiation, but also from a dosimetric perspective, titrate the doses in a way that makes sense for that patient. So how do we do this, and what's the challenge here? So I want to quickly go over some of the fundamentals, I think, of complex systems and also of tumor biology. So this is borrowed extensively from thermodynamics, my background as an undergraduate at the University of Michigan. So what are complex systems, and why do I think it's useful to think of tumors as complex systems? So obviously the human genome is pretty broad. There are over 20,000 expressed genes. That makes for transcriptomic networks. These are perturbed in cancers in distinct ways. So it's a really intricate network of genes that are interacting with each other, which is a feature of a complex system. Complex systems are subject to changes in the output variables based on tiny perturbations in the input. So this is the Lorentz equation, which is a derivation of chaos theory. And so what this states is that, if you have two binary outcomes here, that small perturbations along the route of this complex system can lead to dramatically distinct outcomes. Whether a tornado forms or doesn't can be a representation of minor perturbations in air temperature, ocean water temperature, wind gust, and other factors. The system is more complex than just the tumor cells, of course. We've learned this extensively in the last decade as well with immunotherapy. We know that there's extensive immune repertoire. There are tumor-associated fibroblasts that, frankly, I think are understudied, that have clear impact on tumor cell responses to treatments, as well as to tumor fitness. And the system is open, meaning in this case, the tumor is open to circulation, so there are factors migrating in and out of these tumors. And then the last two features of a complex system is this system is dynamic, right? We tend to not really get a great glimpse of this dynamism in the clinic. We tend to sequence patients at the time of diagnosis. We think that those mutations are fixed, and clonal mutations certainly are fixed in those tumors. However, there's tremendous subclonal heterogeneity. And then when you apply a strong selective pressure, as we did here for a head and neck cancer, so this is actually derived from real data, you see a huge collapse in diversity, and you see a subclone emerge, which is this feature of spontaneous order, that the system now is more representative of the subcomponent of the original tumor than it was of the original tumor itself. So you see tumor evolution and selection and potential genetic drift of this tumor over time. So how on earth can we possibly make accurate predictions in the face of this complexity? I don't want you to despair. There is potentially hope. So we build scaffolds, and we don't think of scaffolds as pejoratives. I think we think of them as intricate and useful. And so clinical trials are fantastic. We'll talk about testing these hypotheses in the clinic as quickly as possible. But of course, the closer you get to human studies, the less manipulation one can do experimentally. So one needs a translational research program that allows you for the ability to manipulate biological systems to interrogate not just association, but causation. And so our lab has been doing this since 2013. We have had tissue acquisition and blood acquisition and data acquisition protocols, mainly in thoracic malignancies, although our studies do extend slightly above the neck and into the abdomen. And so we collect tissue samples, mainly from patients with thoracic cancers. We collect blood. We've done a lot of work in the space, some of which I'll talk about today. We extract biomolecules and profile them. We have developed an extensive inventory of patient-derived xenografts, one of the largest, we believe, xenograft repositories in the world, with a heavy emphasis, again, on lung cancer, but also head and neck cancer. And even to enhance the tractability of the systems even further, we've developed ex vivo model systems, and we're getting into the 3D model space so that there is enhanced tractability even beyond the use of mice, which can be expensive, but as I'll talk about later, can also be high content. The other aspect of this data, of course, is that this is a linked clonomic network. And so every patient that's consented We have, of course, pathological data, EMR data, and imaging data. So this talk is going to be bifurcated into really two separate talks. The first will talk about the genetic aspects of response to radiation, and the other will be focused on image-based features that can be predictive. And then here, the input in the computational aspect of this is really a catch-all. We're really indifferent in terms of what models to use, what type of mathematical models or statistical models to be able to make a prediction. The science is really what drives that, from deep learning, as you'll see later, to information-based similarity indices, as you'll see shortly. And integrating all this data, we're hoping to make some predictions and then test these predictions in the clinic. So what this is what it looks like effectively. Our first effort, published in 2016, was the profiling of the cancer cell line encyclopedia. It's now over 1,200 lines. A vast majority of those lines are leukemias and lymphomas. Leukemias are barely treated or almost never treated with radiation. And so we had profiled epithelial cell lines, so cell lines that were more adherent to radiation using a high content assay. And we made some genetic associations. We recently completed the radiogenomic atlas, which took data from the cell line profiling and tested it in a massively parallel way in a unary fashion, one mutation at a time. And I'm going to talk briefly about PDX-ray, which was launched in 2019, which is an ongoing profiling of 500 patient-derived xenografts. Okay, so let's start briefly at the beginning. In radiation biology, one of the main limitations of high content profiling is the requirement for colony formation assays. These are essential to our field. Since we don't really talk about response rates in the field of radiation oncology, we talk about local control or local failure. And the mimic of that, or the representation of that in the lab, is the colony formation assay. However, that assay is laborious, can be quite costly, both from a media and plastic perspective. So there's been several attempts to develop high content versions of this assay. While I was a fellow at the Broad Institute, we had used the Broad Institute's high content capabilities to be able to develop a microassay using a 384-well format that recapitulates the colony formation assay, or the clonogenic assay. And you can see here we start to approximate using this 384-well format, the low density plating and long incubation after radiation. We begin to closely approximate the clonogenic assay. So what did we learn from this profiling effort of 28 distinct cancer types in the CCLE? But we learned that the intrinsic response to radiation is quite variable. In fact, it could be represented as a Gaussian distribution that approaches normality and meets some statistical tests of normality. So when you look at all of the cell lines profiled, you see a dramatic difference in survival. This is the area under the curve, or the integral survival values across 5 dose points. But in addition to the 28 cancer types, you also see within non-small cell lung cancer, then specifically lung adenocarcinoma, so even within individual cancer types, you see tremendous variation. And the Gaussian is a multivariate model that suggests there are multiple genes that are involved in response to radiation. And so we had identified some genetic associations using this profiling effort. We wanted to be able to ensure that these were not merely associations, but were actually changing the radiation phenotype. And so we devised the following computational approach. We're using the data from the cell line profiling. We identified genes that when mutated, we gave them a label of 1. And then we also identified genes that were mutated within a structured part of the gene. This is in the order. The purpose of this was to enhance the likelihood that that was a functional variant. We labeled that as 1 separately. And then we conducted a similarity assessment that is different than the Pearson correlation coefficient. This is the information coefficient, which looks at entropy, mutual enthalpy and entropy between 2 data sets. And so it's able to capture relationships between your phenotype and your variables with greater sensitivity and not necessarily dependent on a linear relationship. So using that data, we're able to nominate some variants, some mutations, single nucleotide variants that were highly associated with radiation resistance and sensitivity, and that we tested these in a really massive effort using an immortalized cell line background. If the gene of interest or the mutation of interest was a gain of function, we integrated that using a lentiviral vector, leaving the 2 endogenous loci in this immortalized cell line intact. However, if there was predicted to be a loss of function allele from this computational pipeline, then we had to effectively knock out the 2 underlying loci to underlying loci, and we had to do this in a way that was amenable to high content profiling. And so Brian Yard in the lab, former postdoc in the lab, developed a junctional CRISPR approach. And Brian targeted the intron-exon junction of the gene of interest. And what that allows you to do is you become resistant to the lentiviral expressed ORF open reading frame, since obviously the open reading frame does not include an intron. Of course, there's other ways in which one can achieve knockout and then add back of genes, but this was the most facile and really a unique way for us to be able to complete this effort for loss of function alleles. The cells were infected as before at the Broad Institute. We used automated plating with automated readouts, and then we were able to profile the different mutations for sensitivity to radiation. And so this was the magnum opus, if you will, of close to 97 genes, more than 500 single nucleotide variants with their wild type associated genes of interest. And so what you see are really the who's who of radiation sensitivity and resistance, with a heavy emphasis on resistance, simply because our computational pipeline, especially those that looked at mutations within uniprot domains, were likely gain of function, and gain of function was more likely, although not always, to confer radiation resistance. And so our positive control here is NFE2L2 E79K. NERV2 is a frequently mutated gene in tobacco-associated malignancies. And so this was included in every run that was conducted over an 18-month period. And 53BP1 is a gene involved in DNA repair. When knocked out, cells are substantially more sensitive to radiation. So think of this as the dynamic range of this assay, and alleles that fall within one standard deviation of your POSCON, within a standard deviation of your NetCon, are genes that you might want to consider nominating for additional validation. So how did we do? Did the original cell line profiling, which took us close to 24 months, help us in identifying single nucleotide variants that were predictive of radiation sensitivity? And the answer to that is yes. When you partition the data by quantiles, by quartiles of the cancer cell lines, and then look at the associated variants using our radiogenomic atlas, which is again our unary profiling approach, what you saw is if you were more likely to be radiation resistant in cancer cell lines, you were more likely, that variant was more likely to be radiation resistant in this tabula rasa test in the immortalized lung line. There are several in silico tools that are used to predict whether a particular variant is oncogenic, a driver, a passenger, or remains unclassified. So we applied that to the variants that we tested. Hopefully you can see here, oncogenic alleles, again, more likely to be gain of function, more likely to be drivers. Both oncogenic and driver alleles had a higher likelihood of predicting for radiation resistance. However, there were several variants that remain unclassified, variants of unknown significance, so we were able to add some attribution to here using this bespoke phenotypic assay. For example, both of these genes have been extensively profiled, but remain variants of unknown significance in clinical data sets. KEAP1E 117K and row F106L. You can clearly see here that they cause extensive radiation resistance in our assay. So we wanted to retest these. And so you can see here, KEAP1 E117K expressed without the knockout of the endogenous allele, suggesting it's a dominant negative, causes substantial radiation resistance. In ROA, which is an important signaling molecule in the cell, which has been again extensively studied both in silico and biologically. Yet this allele has escaped classification to date, and so we're able to identify F106L as clearly an activating gene in ROA and causes significant radiation resistance. So not only can this help us identify mutations in cancer that predict for radiation resistance, but we can also potentially identify mutations that are activating in these really important genes. So let me give you a vignette about looking at loss of function alleles and using junctional CRISPR. And so in a little bit more detail here, the guide RNA for junctional CRISPR targets the intron-exon junction, and there's actually some nice computational tools that allow you to predict the best guides to utilize. And so as I think all of us know, CRISPR effectively recruits Cas9, which leads to a cleavage site near the PAM site. And so in this particular single clone isolated from KEAP1 double knockout, what we saw was a internal deletion right at the intron-exon junction, clipping aspects of this exon. And so, once the open reading frame of KEAP1 is introduced, this is for the add-back component of the study, there is no longer sufficient homology for the guide to recognize this ORF, and therefore will leave it unharmed. And so, as a demonstration of that, here is KEAP1 with non-targeting control. Once you knock out KEAP1 using this approach, you see loss of KEAP1 plus a empty vector not containing the open reading frame of KEAP1, no expression of protein, and then you add the open reading frame of KEAP1, you see substantial recovery that is, again, resistant to this guide RNA, allowing you to just create across your gene of interest a few single clones, and then you're able to use our library to be able to massively profile using that library, massively profile that gene for multiple mutations. And so that's exactly what Dr. Gopal, postdoctoral, a now research assistant professor in the laboratory, did here. 29 alleles of KEAP1. You can see here there's tremendous variation in KEAP1 alleles. This is a very large gene. The loss of KEAP1 leads to activation of NRF2, which is an important pathway for oxidative stress response, and it's been implicated in resistance to both radiation as well as immunotherapy. So using this knockout and MTC approach, you can identify different categories of mutation of KEAP1. And I think what's really important to point out here is that there is a gradient of effect of KEAP1 alleles. This isn't a binary signal such that a mutation fully activates the gene and then another mutation fully inactivates the gene. You're seeing gradations of effect, so that's why the hypo and hypermorphism nomenclature is being applied here. This is really more of a continuous effect rather than a binary effect, which, if you recall, is really important for granularly identifying patients' responses to sensitivity to this therapy. We were obviously one of the advantages of the radiogenomic ALICE approach is that it took these individual alleles in the absence of other more complex genetic alterations, allowing us to look unfiltered or without the potential confounding effects of other genetic alterations on the influence of these alleles as single events. But of course, cancers aren't created that way. Cancers have many additional alterations that can impact these genes. And so we were really interested in beginning to build towards that complexity, looking at intergene associations. So one could randomly start integrating different variants into cells and potentially look at interesting interactions. However, obviously there's experimental challenges to that in addition to deconvolution challenges to that. And so we decided to take initially a simpler approach, which is to ask the cancer itself for the answer. And what I mean by that is we took the top genes that were nominated that were predictive of radiation resistance, and we looked at a co-occurrence matrix. And we asked, what are other mutations? What are other genes that are frequently co-mutated with these genes of interest? And in the case of lung adenocarcinoma, using TCGA data, we found that KRAS and STK11 were significantly co-altered, and STK11 and KEAP1 were significantly co-altered. So the cancers prefer to have these mutations, these two genes mutated in the same sample, and so therefore, we reasoned that must confer some sort of survival advantage and potentially confer additional resistance to radiation. And so that's exactly what we found in the case of KEAP1. You knock out STK11, nothing really happens from a radiation sensitivity perspective. You knock out KEAP1, as I showed you before, you get substantial resistance to radiation, and then you do the double knockout across several clones, showing two of them here. You see a significant increase above KEAP1, suggesting that there's interaction between these two genes from a radiation phenotype perspective. And similarly with KRAS, these are different KRAS alleles. Some of you may recognize these, the G12s and G13s. There are other alleles in KRAS that occur in the switch-2 domain that also display this phenotype. And so when you knock out STK11 compared to the intact control, you see a shift away from the line of unity, suggesting that there is more resistance upon knockout of STK11, and this is just the orthogonal distance to that slope. And so you can see some variation in the specific alleles of KRAS in terms of the effect, the interaction effect, which we'll come back to shortly. The other question is, of course, we put this into this BS2B, which is SV40 immortalized, doesn't have a ton of other genetic alterations, no salient alterations that appear to be important in cancer after whole exome sequencing this immortalized cell line. But what happens if you introduce it into a cancer cell line, a bona fide cancer, or even a bladder line that's been immortalized using another approach, not SV40? And so this is the test that was conducted. We took some of the salient alleles that conferred radiation resistance along with their wild type counterparts, and we profiled them across bladder line as well as NCI H520, which is a lung squame line. And hopefully what you can see here is a concentration in the first Cartesian quadrant. So think of this as a dartboard, and if you were to throw darts randomly at this dartboard, the darts should theoretically land in all four quadrants. But the fact that we took mutations that conferred resistance in BS2B, if you see an increased concentration in this first quadrant, then they are more likely than mutations that are likely to be resistant in BS2B are more likely to be resistant in the other cellular context. And when you run a statistical test, you see a significant enrichment in quadrant 1 for the vast majority of these alleles. There are some exceptions. There are some variants that appear to be cellular context specific, and we're certainly interested in following up on that. But generally speaking, when you take a strong phenotype, for example, the NRASs, they appear to confer resistance across multiple cellular contexts. So another vignette on the genetic side is we were interested in high dose per fraction effects. And so as some of you may be aware, radiation can be delivered daily incrementally over several weeks, or it can now, I think a growing trend in our field is to be able to deliver high doses in shorter intervals. Patients complete treatment faster, and the efficacy seems to be substantially higher, at least from a local control perspective. And so we were interested in identifying genes that conferred resistance specifically to higher doses of radiation rather than lower doses. And so on the top of that list was KRAS. KRAS, as all of us know, is frequently mutated in many cancers, but especially in lung adenocarcinoma, where about a third of lung adenocarcinomas have KRAS mutations. And so we took all of the KRAS alleles and retested them in the BS2B, and we saw significant concordance across replicates. You can see here at 2 gray per fraction, very little log fold resistance. And as we increase the dose, you begin to see enrichment of resistance, at least for some of the KRAS variants. What's really interesting is these rare switch 2 variants, Q61, the Q61s in particular, and perhaps A59G, tend to confer a substantial more level of resistance, and there may be some interesting molecular reasons for that. However, not all KRAS alleles did confer resistance. And again, back to the granularity that's going to be required to be able to make these predictions. So for example, D33E, which is clearly oncogenic, shown by Bill Hahn's group at Dana-Farber to be oncogenic, conferred no effects on radiation sensitivity. So clearly, even within a strong oncogene, not all variants are created equal, and in fact may have different transcriptional programs. And so we use a clinical data set from here at Northwestern. We've been genetically profiling patients since 2011, initially with KRAS and EGFR, subsequently with gene panel sequencing. We're now up to 500 genes for all newly diagnosed lung cancer patients. So this is what the data set consisted of, effectively patients with high dose, treated with high dose radiation over a period of 8 years. We profiled patients who had KRAS G12V, as this patient did, were treated, and those that did not were treated with just focal radiation, no mediastinal radiation. Patients underwent a PET CT scan. The radiation was delivered. We assessed response, and this could be really challenging because of significant fibrosis that can be reduced by high dose radiation to the lung. And then we assessed for local failures, both radiologically and in some cases via biopsy. Biopsies are attempted as much as possible, but sometimes there are limitations to ability to biopsy patients after high dose rate radiation, namely because of comorbidities and the possibility of inducing a pneumo. So this is what our data set's comprised of. There are multiple KRAS alleles that we were profiling. This mainly confined to G12 and G13. This was the nature of the type of sequencing, hybrid-based sequencing technology that we were utilizing early on. We're now able to identify switch 2 domain mutations using our panel sequencing effort, but in the historical data, we were really confined to G12 and G13. The vast majority of patients received homogeneous doses of radiation. 10 gray per fraction, 100 gray BED. The KRAS tumors weren't larger, and that's important to point out because larger tumors tend to fail radiation at much higher rates than smaller tumors. And so in a multivariate model that comprised of the genetic label, which in this case, KRAS mutation, yes, no, versus tumor volume versus dose, genetic variable was the only predictor of local failure. And you can see here the hazard ratio is about 2.7. So this was clinical evidence that at high dose per fraction clinical treatments, patients with KRAS mutations were more likely to fail this therapy. We're really interested in advancing this concept. This is an increasingly growing space in the med-onc field using KRAS inhibitors, G12C, both sotorasib, this is the Amgen compound, as well as adagrasib have been FDA approved for use in the metastatic setting. And so we wanted to conduct a possible interaction study with KRAS G12C inhibitor, sotorasib, and radiation. And so we took 3 of our PDXs, KRAS wild type, KRAS G12V, and KRAS G12C, and focus just on the green line for just a second. This is sotorasib, which should only respond. And so patients were given sotorasib here for 21 days. And so you should only really see response in the KRAS G12C, which is true. There's a slight effect on the G12V, but I think not statistically significant. Some interesting, although these tend to be specific, we've observed this across other alleles that the G12C inhibitor could potentially affect other mutations in KRAS. Radiation alone is shown here in blue, and then the interaction is really sequence dependent. And so when you give radiation followed by sotorasib, you see a substantial reduction in tumor volume. In fact, we let these go for another 100 days or so, and we don't see tumor recovery. However, if you inverse the sequence, you give drug followed by radiation, you don't see an improvement in tumor responses. And the reason for that, and we can get into in the questions, if anybody has any questions about that, is once you release the drug, you get a rapid recovery of KRAS signal, a flare, if you will, mitigating the effects of giving a drug first followed by radiotherapy. There are other studies that are ongoing to be able to increase our scalability for decoding the genetic basis of radiation sensitivity. I'm going to go through this quickly because I want to get to the imaging component of the talk. And so Radiogenomic Atlas took us approximately 18 months to complete. It uses this laborious unary profiling effort. It uses an arrayed platform. This is one of my colleagues, former colleagues in Matt Meyerson's group. It took Alice close to 24 months to profile 194 somatic variants for simply gene expression using the Broad's L1000 platform. And so we need to be able to look at these mutations because they're so numerous, and we'd like to capture more of them. We'd like to be able to profile them in a higher content way, in a less laborious way. And so just really briefly, the arrayed approach has advantages. You know exactly what mutation you've introduced into what well, and has resolution advantages. But of course, it can be quite laborious because of whether it's automated or manual pipetting. It's really not scalable. Pooled screens, on the other hand, have the advantage of being scalable. One can look at thousands and thousands of variants in a single flask, however, has the potential limitation of deconvolution and ensuring your signal to noise ratio is adequate enough to identify your phenotype. And so we're moving towards a pooled format that's, I would say a hybrid pooled format. And so as I showed you, there was tremendous variation across KRAS alleles in our radiation sensitivity profiling effort. We strongly believe that we need comprehensive genetic annotations of mutations in salient genes, KRAS, KEAP1, NFE2L2, STK11, and so on and so forth. And so single-site mutagenesis is going to be our approach going forward. For those of you that aren't familiar with this approach, single-site mutagenesis is saturation mutagenesis, takes every individual amino acid in a protein and converts it to all other 19 amino acids, and can actually also introduce a stop codon. So you're able to convert in iterative fashion all amino acids in your gene of interest. And so one can do this and identify these mutations by sequencing, by DNA sequencing. However, we also wanted the additional advantage of coupling this with single cell RNA sequencing. And so Alex Musecki, who's a MD PhD student in the laboratory, devised this really cool technique of being able to link single site mutagenesis libraries with 10x's capability to look at transcriptomes and within single cells. I won't get into the granular detail, but he designs this trap-seq approach with a barcode. And so we're able to, in a pooled fashion, introduce mutations in cells and then look at not just their response to radiation using DNA-seq and other capabilities, but also look at their single cell space. So for example, as a proof of principle, Alex introduced KRAS G12C, KRAS Q61H, and KRAS wild type into the BS2B immortalized cell lines, mixed them together, and then we conducted single cell RNA sequencing on these three alleles. And what we find is that we're able to pull out the individual mutations using this barcode approach. And so we can mark individual cells with these mutations. And hopefully what you can gather here is that although the mutations certainly occupy different t-SNE space than the wild type, you can see tremendous variation in individual cells that express these mutations. And so with Q61 occupying a distinct t-SNE space here, that may explain the radiation phenotype. And so we're going to obviously do this on a more massive scale and introduce the entire library into the BS2B cell lines, and we'll have transcriptomic data in addition to phenotypic radiation data. And therefore, not only will we be able to identify which mutations confer resistance to radiation, but also potentially identify why the different mutations confer different effects, and then tease out some of those molecular pathways using transcriptomic data. So we're really excited about this. We've developed an extensive inventory of patient-derived xenografts. This is really representative of our patient population of most academic clinical center stage populations in lung cancer. And so these patient-derived xenografts have high fidelity, both transcriptomically to the primary tumors. We and others have shown this, as well as genetically, and I'll show that in just a second. So our PDXs are being profiled using high content capabilities because of the inter-observer and measurement differences across different operators. We're introducing laser technology to be able to measure tumor volumes with automated capture of 3D volume from the flank of the tumor. The mice will be engrafted with radio frequency probes in the ruff of their neck, identifying that particular mouse in its experimental condition. And then automated scanning will be done at least twice a week. We intend to profile 10,000 mice, 500 PDXs over hopefully a span of two more years. And so this is the design. It's a 4x1 design. Every dose, 4 mice will be included in individual doses from 2,4 to 610 gray. We're really interested in several questions here. Not only are we interested in potential radiation sensitivity across the cohort, but we're fascinated about the co-clinical trial concept. So these patients these tumor samples are derived from our patients. Some of these patients receive radiation and some of them receive just radiation alone in the context of SBRT to the lung, high dose radiation to the lung. And so we want to assess the concordance between the response in the mice versus the response in the human. We're interested, again, in this, what happens after radiation? How does the tumor evolve genetically, transcriptomically, epigenetically? So we'll be able to conduct those studies on a massive scale. We're interested in the question of geographic stratification. If we've isolated using surgical samples, we isolated PDXs from different regions of the tumor, and we'd like to understand how spatially intrinsic differences might occur due to genetic divergence spatially within these large tumors, especially these large squamous cancers that our surgeons have been able to remove. We've begun genetically and transcriptionally annotating our PDXs, and it's encouraging to see that in non-small cell lung cancer, they mimic what you typically would see for a non-small cell lung cancer cohort with significant mutation frequency of 53, KRAS, KEAP1, STK11, NERV2, which tends to be rare in lung adenocarcinomas, where we're able to identify clearly activating mutations in NERV2. So our PDX data set is certainly robust enough to capture both frequent and rare mutations in non-small cell lung cancer. And as a last component on the biological side, these PDXs, although traditionally thought they are engrafted in immunocompromised animals and traditionally thought to be immune naive, do in fact have an extensive immune repertoire, at least in early passages. This is CyberSort on our first tranche of RNA-seq extracted patient-derived xenograft cohort, and you see an extensive repertoire of T cells, Tregs, NK cells. And so we do think, and in addition to tumor-associated fibroblasts, and these tumor-associated fibroblasts, that's what CD44 is here, are certainly not mouse using MAC class 1 for mouse. These are human-derived tumor-associated fibroblasts. And so, hopefully you can see that this sort of both inductive and deductive approach where we can take a human PDX and not just look at intrinsic differences in sensitivity across the cohort, but potentially look at immune interactions, also fibroblast interactions, and the effects of these interactions on radiation sensitivity can be studied at scale. So these models are substantially more useful than simply intrinsic effects. So I want to pivot here and talk about image-based analysis. I think it's complementary to what I just talked about. So obviously there's been extensive effort on the genetic and biological side, both in medical oncology, but there's growing interest and I think increased interest in using image-based capabilities. And that's been mainly associated with the enhancement in deep learning and artificial intelligence computational capabilities over the last decade to decade and a half. So I want to start off by really a rhetorical test. A human conducted a manual segmentation of a set of these contours, and a machine conducted the other. Obviously this isn't the right platform to be able to ask this in an interactive audience, but I can guarantee you over a relatively large population that the error rate is about 50%, that it's very, very challenging for a human observer to identify the differences between these two contours. And so, as some of you may know, in radiation oncology, we have to identify organs at risk. So these are normal structures, and what you are seeing there are critical structures both in the lung and the mediastinum. And so, clearly the machine is able to perform some, I would say mundane tasks from a radiation perspective, which is OAR segmentation. I'm sure our residents would love to get away from manual segmentation, as would our clinicians. But so clearly, I think we're close, if not already there from a workflow perspective. There are several software capabilities on the market. But in addition to those capabilities, this is obviously human lung tumors and other tumors that are close to the chest move as a function of respiration. And so these contours are mobile. Using the machine, you can contour across the 10 different phases of respiratory motion, allowing you to look at motion effects in ways that were really very, very difficult to do in a scalable fashion in a clinical workflow setting historically. And so we think that there is extensive promise in the ability to use deep learning and image-based analysis to be able to not only enhance workflow, but to actually even make some frontal lobe decisions, such as what dose to deliver to the lung. So a Turing test, just by the way, that was sort of a subjective Turing test, although you didn't participate. A Turing test is that, can a machine capability fool a human observer, whether that observer is an expert, or with intermediate experience? Can a machine produce a product in which a human is not sure whether it came from another human or a machine? And if you pass the Turing test, you meet at least some standard of AI being potentially workable for your task of interest. So I'm a big fan of Isaac Asimov. There's a lot of debate, of course, about artificial intelligence and its use, especially in medicine, with the potential for some rogue capabilities causing extensive damage. And so, I think these are important things to consider when trying to implement artificial intelligence capabilities. And how do you design a QA program, especially as you enter clinical testing? How do you design a QA program that can mitigate some of these concerns? And people always forget about the zeroth law of iRobot, which is a machine may not harm humanity, or by inaction allow humanity to come to harm, right? Okay, so why do we need more frontal lobe functions? I mean, it's great that you can do OIR segmentation. It's going to make a lot of us more efficient. A lot of us, enjoy our jobs a little bit more because of less mundane tasks. But we need to be able to implement this for higher order functions, especially tumor segmentation, which tends to be substantially more challenging, and the machines have yet to solve that problem. So humans are wonderful. We do a lot of really great things, but we do have limitations. So for example, there is tremendous variation in inter-observer focus. So for example, this is the classical painting, The Unexpected Visitor by Yarbouk. This was a classical optics experiment in which sensors were placed on the muscles of the eye, and different observers were asked, and each of these represents a different observer, were asked to identify the socioeconomic status, in this particular case, of the individuals in this painting. And you can see the different tracks that individuals took. There's some potential concentration where the individuals are, but you can see others are just kind of all over the place. So not only is the path to the focal point different, but the focal points are different across different observers. So, a tumor may be in the eye of the beholder, so to speak. This is a scintillation grid, another aspect of our visual apparatus. This is not real. You're seeing them blink, but they're not actually blinking. Again, a potential limitation, especially when looking at black, white, and gray voxels continuously over an hour or more as you're trying to decipher what is tumor and what isn't. And in addition, from a resolution perspective or contrast perspective, the human limit is typically around 1 to 5% with tremendous variability that is dependent on many factors, including age. Nonetheless, I think that makes more salient the ability to be able to automate this process, not just for normal structures, but also for tumors. And so this is a really nice review published in 2019, in which the prediction that AI and clinical integration, it's going to improve our workflow, potentially the reconstruction algorithms are going to be faster. There's going to be improvement in image interpretation, in registration, where you take two different images and you either do rigid or deformable registration to make sure those images roughly approximate each other. But however, the higher order function was supposed to come decades later. So we thought to stay a step ahead. What is deep learning? I want to demystify it if I can in the short time that I have left. Deep learning is effectively a series of matrix algebra with some weights that are adjusted in a way that optimizes the training model. So effectively, it isn't magic. It is a way of using extensive amounts of data and tuning that data in the relative input of individual, in this case, voxels and the interpretation of those voxels to be able to make an accurate prediction. And so it's really just matrix math. And the one really cool feature of it is when the algorithm makes a mistake, there's a way of punishing it for making that mistake using gradient descent, and it tries to find the most optimal solution to minimize the error rate. And if you do this over many, many images and many iterations, you're able to find a reasonably well-trained model that can predict in a holdout set pretty accurately. So the key is a volume of data, but the algorithm is really no more advanced than linear algebra in differential equations. So historically, obviously, we use CT imaging data as mainly qualitative. We look at things and we make interpretations. And again, we've talked about some of the limitations of that. But there's a substantial amount of quantitative information in each individual voxel, basically the Hounsfield unit or the intensity, the absorbed intensity in each voxel. And I want to make the point that why are we seeing an increase in use of deep learning? Number one, the deep learning is substantially more scalable. It has performance that dramatically increases as a function of the size of the data, whereas traditional machine learning algorithms, this is a function of overfitting bias, tends to do well with relatively well faster than deep learning initially, but then tends to plateau. So the increased interest is because deep learning is substantially more accurate than traditional machine learning algorithms for specific tasks. And so the task here is similar to the vignette that I gave you on the KRAS side, is really what are the imaging predictors of response to high dose radiation. So for that, we look at the clinical outcome here. So it's about 80% successful across our historical data set. And one would say, well, look, humans already do a good job. Why would you want to optimize something that's already 80% successful? That's exactly what deep learning models are intended for. They're intended for tasks that we're relatively good at, but need to be more consistent on and potentially optimized to improve beyond the current human plateau. And so that's what we decided to do. And the other interesting part of this data set is that as you increase the dose of radiation, you see a substantial reduction in the local failure rate. And so we wanted to train a model that utilizes image-based features alone to be able to make predictions about the likelihood of local failure after high dose radiation to the lung, and then also potentially adjust the dose and test that model prospectively. And so this was published in 2019. We developed a multi-task model that has two specific tasks. We asked it to reconstruct classical radiomic features, but in addition to make the prediction about local failure. This is to constrain the model in a way to mitigate overfitting. And this is a scalable, the multitask fashion is scalable here. So if the additional task of reconstructing classical radiomic features isn't helping with a classification task, that gets tuned down as the data size increases. And so the output here is an image risk score. And from that image risk score, we're able to make time to event prediction. We make the image risk score a function of the hazard ratio. And so we're able to use Cox regression here to be able to make a prediction as a function of time. This image-based risk score does really well at predicting local failures from high-risk groups and low-risk groups of having failures. It functions well across different stages of non-small cell lung cancer, as well as METs to the lung. It does substantially better than traditional two-dimensional CT size, maximum 3D diameter, and classical radiomic features. So this is just the image risk score alone at 0.71. It's scalable across the satellites. And so one can train a model at main campus and then test it at satellite sites. And you can see here, although the demographics and the tumor sizes were different in the satellites, there was a substantial, it was able to predict local failure with a hazard ratio of 5.13 in 9 distinct community sites. We're interested in we developed a regression model that takes the image risk score as a function of the dose of radiation delivered. And so you can see here, as you increase the dose of radiation, the local failure probability based on the image risk score dramatically decreases. The higher the risk score, the higher the probability of local failure. And so now you have effectively a linear relationship between dose, although that might not be the case clinically, but using this regression model, we're imputing a linear relationship between dose and local failure probability. And so using this relationship, we're able to extract an idealized dose of radiation that would have prevented local failures to a rate of less than 5% at 2 years. And that's what I-gray is. And so it's a deep learning based output that predicts, that estimates the dose necessary to keep local failure less than 5% at 2 years. And obviously this would be a continuous variate, whereas humans, we tend to give really nice and round numbers and round doses. This is based on some phase 2 studies in our field. And so we're hoping to move away from this one size fits some or one size fits all approach of radiation prescriptions to a more granular type of radiation prescription model. This is this is looking at the benchmarking of this across multiple years, the estimated outcome versus the observed outcome. And this is the concordance index as a function of the volume of the data. You can see here, deep learning is really data hungry. If you drop the data by 60% of the input size, you see a dramatic reduction in the performance with it, whereas volume tends to plateau early, again, consistent with the ML versus DL differences in scalability. And so as we increase the data set size, when do we plateau with deep learning? That remains to be seen. I'm sorry, maybe somebody had a question, but I'll just finish up here in a slide or two to leave time for some questions. Obviously, these tumors are in motion. So when you say you're extracting a deep learning score from a free breathing image, that's the average intensity position of that image. So we were able, there's a lot of concern in the field that when the tumor moves, that all bets are off, that the whatever intelligence you're able to derive from the image is distorted. That's not true. What happens is actually that as the tumor is moving, the DL score also undulates in similar fashion, in a sinusoidal fashion with respiratory motion. These are small scale undulations. You can see here the error with motion. And so we do think, although we can account for motion and potentially calibrate it away or incorporate it into the model. More recently, we conducted external validation. So our original training cohort was done at the Cleveland Clinic. And then we applied that to our data set here at Northwestern University. In the interest of time, I'll just jump to the salient findings. We were able to show that, in fact, a deep learning model learned at a separate institution with obviously different instruments and different machines, although the CT simulator type was the same, but from different years of acquisition across different demographics and different tumor sizes and different therapeutic approaches, we saw the ability of this deep learning model to transport well to our clinic here. And you can see here the concordance index in the internal data set, the Cleveland Clinic data set versus the Northwestern data set, so effectively indistinguishable as it relates to the C indices. And so we also implemented the use of I-gray, and we asked the question, if you were greater than or equal to this ideal dose, what was your risk of local failure? And you see here that if we match the I-gray dose to historical, if we imputed an I-gray dose historically, and the actual delivery of that dose was less than or equal to the I-grade dose, you saw no local failures. But as the discordance between the idealized dose and the actual dose delivered increased, then you began to see higher risk of local failure, suggesting that not only is the image-based analysis transportable, but also this regression model might be transportable. So we're going to test this. We're going to test this prospectively. This is about to launch. We're about a month away from launching this. Effectively, we're taking early stage and oligometastatic patients, exactly the same population that we use for the training data set. We're going to use the image-based analysis here as the driver of the prediction of dose. We're going to guide the physician in terms of what dose to prescribe. They can deliver that within a 10% window of the recommended dose, with more or less than that being a minor deviation. And we're going to follow patients. It's a single arm study, so we'll be comparing to historical controls. There's a ton of things that go in the background of developing these models, including a rigorous QA program. We're going to be working with IROC at MD Anderson to ensure that image quality is sustained throughout the enrollment period, as well as that the model is stable. And so this is obviously a fixed model, but we want to ensure that it's making accurate predictions. And so there's some rigorous QA program that we've instituted to be able to do this. I'm going to skip ahead here in the interest of time. Really briefly, we're interested in tumor auto segmentation as well. We're pretty close to finding, I think, a reasonable solution to be able to segment tumors such that not only are organs at risk and automatically contoured, but potentially also tumors with obviously physician oversight and physician guidance ultimately. So I'll end with this. I'll just leave this up to leave some time for questions if anybody has any. But effectively, thank you so much for your time and attention. I'd like to thank members of the laboratory, both historical and currently, for all the great work that they've done. And I'm happy to take any questions that you might have.
Dr. Abazeed, I do have a question. Obviously, you've done all of this work in the lung cancer world. And do you sort of anticipate or envision something like this sort of being translated to other cancers at some point?
Yeah, I mean, look, I do think there's two ways to answer that question. I do think genetic alterations and image-based capabilities can be transportable to other organ sites. I think I showed you cellular context and genetic context being not as important as we frankly thought it was going to be. So, for example, in hepatocellular carcinoma, NRF2 mutations aren't found. However, the NRF2 pathway by p62 overexpression is a frequent co-occurrence in hepatocellular carcinoma. So we do think some of that capability is translatable to other sites. Obviously, data set size, the biological resources are going to be a challenge. We need to have the right tissue acquisition protocols to be able to get the right pipeline in place for other sites. On the image side, I think potentially substantially more scalable. We just need images and some clinical data. So to answer your question, absolutely. I just think it's going to require some effort.
I see. I think Dr. Sassman has a question.
Yeah, Mohamed, that was just a great talk, even though there's so much data there. I'm not sure I could keep up, but there are two questions, sort of question areas. One, is there any way to model radiation and immune therapy? I'm not sure I really believe the whole paradigm, but is there a way to look at it in your models? And then the second thing, is there some value at making sure you include the region immediately around what you see on the scan? Are there cells there or tumor that you can't really appreciate that really need to be killed, and we might be limiting it? Go ahead.
Yeah, great question. I'm also a skeptic of the combination of radiation and immunotherapy. I think a lot of those studies, a lot of the initial excitement was done in genetically engineered mouse models that are highly immunogenic. And so I think as we were conducting the clinical trials, I think we had an optimistic perspective of the likelihood of interaction between immunotherapy and radiation. These PDXs, as I think I alluded to briefly, do have an immune repertoire. So the plan, Jeff, is to be able to parse this out. So using a classical reconstruction assay where you remove components and look at the effects of the individual immune cells, and then adding different components together to look at the potential interaction between radiation, the intrinsic effects as well as extrinsic effects of radiation sensitivity. I frankly think that human fibroblasts have a stronger impact, and there are different human fibroblasts, but we'll conduct those studies and be able to ferret that out. To your second point about the periphery of the tumor, that is really, really important. So in classical radiomics, you typically included only the gross tumor volume and didn't include the peritumoral area. However, this is the classical paper by Hugo Ertz, which was the largest scale study for classical radiomics. So you can see here, elements of the neighboring cells, but really it was just the gross tumor volume. What we do is that we create a bounding box around the gross tumor volume that incorporates the peritumoral issue, even if it abuts the chest wall or the mediastinum. We'd like to incorporate that information. Is there data to suggest that that's important? Not necessarily by us, but we certainly wanted to look at the potential for microscopic disease that isn't observable to the human eye. And so this is one of the last slides that I skipped over. If you notice, so this is what's called a saliency map. A saliency map says, tell me what voxels are the most important in your model for predicting the outcome of interest. And so the blue here is the gross tumor volume. And you can see, if we were to turn off the lights or make this a little bit darker, and hopefully you can see it from the screen, there are some red voxels, high saliency, that extend not just beyond the gross tumor volume, but also beyond our volume that incorporates the setup area, the planning tumor volume. So you will see in this high dose treatment, precipitous drop in dose as we beyond the planning target volume, and about 20% of those voxels are beyond the PTV. And so it's intriguing, right? I mean, others will argue saliency maps are unstable, they're not as robust, they're really unreliable. And so it's quite preliminary, but to your point, yes, absolutely. I think we know from surgical samples that there is asymmetric microscopic disease that extends beyond the gross tumor volume observable on a CT scan. And of course, CT scans come with different qualities, although we tend to think we're highly standardized. I think there's still some substantial variation. So obviously we'd love machines to be able to capture that ultra-sensitive detection at the periphery of the tumor. Great questions.
I think Dr. Chowdhury, I think, has one question. We might make that as the last question in the interest of time.
Sure.
Sonali, I don't know if you Are you able to hear? We're not able to hear you. Maybe not.
Yeah, I guess not.
I guess not. I do want to thank Dr. Abazeed. That was an excellent talk. Thank you very much.
Thank
And
you.
just a quick reminder, next week is an in-person grand round. So be on the lookout for information about that, and we hope to see everybody in person next week. Thank you, everybody.